Hi, welcome to Geriatric Syndromes Part 2. I am Dr. Everton Prospere. I am a medical attending in the Department of Medicine at SUNY Downstate Health Sciences University. I'm also the director of the Geriatric Medicine Fellowship Program, and I'm a co-director of the Brooklyn Initiative to develop geriatric education. So today's talk, this session, is on geriatric syndrome Part 2. We'll be examining pressure ulcers or pressure-induced skin injury, gait abnormalities, falls, and urinary incontinence in older adults. I have no significant financial disclosures or conflicts of interest. However, this presentation is supported by a grant from the Health Resources and Services Administration of the United States Department of Health and Human Services. And this presentation is also part of a broader geriatric curriculum. The curriculum consists of self-learning modules, or BRIDGE, Brooklyn Initiative to Develop Geriatric Education modules, consisting of topics on the comprehensive geriatric assessment, wellness and functional ability, interprofessional teams and interprofessional care of the older adult, age-friendly healthcare systems and the 4 M's framework, dementia-friendly communities, geriatric syndromes 1 and 2, culturally and linguistic competent health care of older adults, and ageism. This is a glossary of some of the commonly used acronyms or the commonly used abbreviations that are used throughout these SLMs or self-learning modules. HRSA, Health Resources and Services Administration, GWEP, GWEP, Geriatric Workforce Enhancement Program, BRIDGE, the Brooklyn Initiative to Develop Geriatrics Education, CIAD, Center of Excellence for Alzheimer's Disease, 4 M's framework or the 4 M's healthcare model. The 4 M's stands for what matters: medication, mentality, mentation, and mobility. Bridget, which is the Bridge Interprofessional Team, ADRD, Alzheimer's disease and related dementias, Bridge Gap, the Bridge Integrated Geriatrics, Primary Care, ECHO, Extension for Community Health Outcomes, and SLM, which is, again, self-learning modules. So this is a very interesting slide. This slide represents the 4 M's framework or the 4 M's healthcare model. The 4 M's stand for what matters: medication, mentation, and mobility. And it's part of the age-friendly healthcare system. The age-friendly healthcare system is an initiative of the John A. Hartford Foundation and the Institute of Healthcare Improvement in partnership with the American Hospital Association and the Catholic Health Association of the United States. This is a very interesting collage. It's a snapshot of the various settings in which we find older adults. So where do we find older adults? Older adults can be found in settings ranging from the intensive care unit to the residence, skilled nursing facility, assisted living facility. Older adults can also be found basically anywhere, touring the world and living it up. So what are the objectives for this presentation? By the end of this module, all learners will be able to 1. Define pressure injury, 2. Identify the major risk factors, clinical manifestation, and consequences of pressure injury, 3. Describe pressure injury staging system and treatment strategies, 4. Describe the specific geriatric syndromes of urinary incontinence, gait abnormalities, and falls, and finally, the learner should be able to identify the diagnostic and therapeutic approaches to the management of urinary incontinence, gait abnormalities, and falls. So, what is a pressure-induced skin injury? What is pressure-induced skin injury? Why is this relevant? This is relevant because we practice evidence-based medicine. In other words, whatever we do in medicine, our assessments and our interventions should translate into an improvement in quality of life and life expectancy. And whatever we do in caring for the older adult, it should be guided by the principles of the 4 M's framework. Our interventions and assessments ideally would translate into an improvement in quality of life and or life expectancy. It should promote independent functioning. Why is this relevant? It's also relevant because evidence suggests that early detection correlates with better, quicker healing. So let's brainstorm. What is a pressure injury? And what are the consequences of pressure-induced skin injury? The skin is the largest organ in the body. And because the skin is the largest organ in the body, the skin can also fail, or the skin can also become diseased. Pressure-induced skin injury is only one of a diverse group of chronic skin wounds, and therefore pressure-induced skin injury must be differentiated from other skin lesions. Pressure-induced skin injury should be differentiated from moisture-associated skin damage. This includes skin damage that's caused by or triggered by dermatitis that's induced by urinary incontinence, dermatitis that's induced by diarrhea, and dermatitis that's induced by fistulas and or wound exudates. Pressure-induced skin injury should also be differentiated from skin changes related to underlying infections, skin infections. It should be differentiated from medical adhesive-related skin injury and traumatic wounds such as skin tears, burns, and abrasions. Pressure-induced skin injury should be differentiated from skin changes related to or ulcers related to arterial and venous insufficiency and skin changes related to autoimmune and vasculitis ulcers. And finally, pressure-induced skin injury should be differentiated from neuropathic ulcers. So what is a pressure-induced skin injury? A pressure-induced skin injury is a localized area of skin damage or a localized area of damage to underlying soft tissue as a result of pressure or as a result of pressure in combination with shear. Okay? Pressure-induced skin injuries are usually formed over bony prominences. The risk of a pressure-induced skin injury is greatest on the skin over the sacrum, followed by the skin at the area of the heel, followed by the skin at the area of the ischium. Pressure-induced skin injury is usually related to immobility. So individuals who are bedbound or individuals who are confined to chairs tend to have a higher risk of developing pressure-induced skin injury. The National Pressure Injury Advisory Panel elected to change the term or change the name from pressure ulcers to pressure-induced skin injuries, primarily because, one, not all skin damage due to pressure results in skin ulceration. Again, not all skin damage that is due to pressure results in ulceration. And secondly, deep tissue pressure injury may not result in ulceration. So the term pressure-induced skin injury is more appropriate than the term pressure ulcer. So what are the stages of pressure-induced skin injury or pressure injury? Generally speaking, there are 4 stages. The first stage is stage 1, which is characterized by intact skin with a non-blanchable redness. Stage 2 is characterized by partial thickness loss of the skin. Stage 3, full thickness loss of the skin. And stage 4, full thickness tissue loss with exposed or visible bone, exposed or visible tendon, exposed or visible muscle that is directly can be appreciated or directly palpable. So the following is an image of a stage 1 buttocks pressure injury. This is characterized by skin with a non-blanchable redness. And the non-blanchable redness remains even after an hour when the pressure is removed. It's important to note also that darkly pigmented skin may not have a visible blanching lesion. In addition, this stage 1 pressure injury may be painful, it may be firm, it may be red, and the temperature is different than the surrounding area of normal tissue. This is a picture of a stage 2 buttocks pressure ulcer, pressure injury. It is characterized by partial thickness loss of the skin with a shallow open ulcer with a red-pink wound bed without any slot. Partial thickness loss of the skin, stage 2 buttocks ulcer, may also be characterized by intact blister or an open ruptured blister filled with serum or filled with serosanguinous fluid. And finally, a partial thickness loss of the skin with shiny or dry shallow ulcer without slot or without bruising. This is a stage 3 ulcer. It's found in the hip region. It's characterized by a full thickness loss of the skin. It's also characterized by subcutaneous fat that is visible. However, the bone, tendon, and muscle is not visible. Okay. Also, in stage 3 ulcer, slough may be present, but the slough does not obscure the depth of the tissue loss. And finally, undermining and tunneling may be present. This is a stage 4 hip ulcer. It is characterized by full thickness tissue loss with exposed visible bone, exposed visible tendon, and exposed visible muscle that is directly palpable. Okay? Eschar or slough may be visible. And in contrast to stage 3 pressure ulcers, where undermining and tunneling is sometimes present, in stage 4 pressure ulcers, undermining and tunneling is frequently present. Some pressure ulcers are unstageable. The following are 2 images of unstageable pressure injury. The image on the left is a full thickness tissue loss in which the actual depth is completely obscured by the presence of a black or a dark scar or slough in the wound bed. On the right, it's an image of a deep tissue injury. Again, the depth is unknown, but is characterized by a purple or maroon localized area of discolored intact skin. Also, a blood-filled blister due to damage or underlying tissue may be present. Other pressure ulcer or pressure injuries include unavoidable pressure injuries. Unavoidable pressure injuries are pressure injuries that develop despite the provider's holistic approach, and this includes the provider evaluating the individual's clinical condition and pressure ulcer risk factors. This includes the provider defining and implementing interventions consistent with individual needs, consistent with the goals and recognized standards of practice. And finally, this includes after the provider has monitored and evaluated the impact of interventions and after adjusting for the diagnostic and therapeutic approaches as appropriate. These pressure injuries may be a marker of significant underlying disease and impending death. So what are some of the major risk factors for pressure injury? The major risk factors for pressure injuries include immobility, low blood flow, compromised nutritional intake, and sensory loss. In terms of mobility, individuals who are confined to bed, individuals who are, let's say, confined to chair, or individuals who have a neuro or psychiatric underlying problem and impairment with mobility have a higher risk of developing pressure injuries. Okay, in terms of low blood perfusion, decreased skin perfusion, especially when pressure is applied at dependent areas, increases the risk of developing a pressure injury. And usually if the pressure is applied longer than 2 hours. The risk of developing pressure injury is greatest at the sacrum, followed by the heel, and followed by the ischium. Compromised nutritional intake, again, is a major risk factor for developing pressure injury. Overall, poor nutrition and decreased caloric intake increases the likelihood of an older adult developing pressure injury. Age greater than age 75 years with associated malnutrition and weight loss increases the risk of developing pressure injury as much as 4 times. There's no associated increased risk of developing pressure injuries with any specific deficiency in vitamins or minerals. Sensory loss is also very important. Decreased or lack of sensation may lead to diminished pain and diminished perception. This can be found in conditions such as diabetes with underlying diabetic neuropathy, strokes, and CVAs, and spinal cord injury, where motor and or sensory function is impaired. In terms of risk assessment, the Braden scale is the most widely used pressure injury risk assessment tool. It has been validated in homes, it has been validated in skilled nursing facilities or nursing homes, and it has been validated in the hospital setting. It has not been validated in intensive care units. The Braden scale utilizes sensory perception, moisture, activity, mobility, friction, and shear, and it also recommends considering clinical judgment. So what's the prevalence, what's the clinical manifestation, and what's the consequence of pressure injuries? In terms of prevalence, as many as 300 million Americans are impacted by pressure injury. In terms of hospitalization, as much as 16%, almost 16% of patients in acute care settings have pressure-induced skin injury. In long-term care facility, that rate increases to approximately 32%. And in patients or individuals who are terminally ill, the risk approaches 55%. In terms of the economic impact or the economic burden of pressure injuries, and this is data that's presented by the Agency for Healthcare Research and Quality. Pressure injuries has been designated as a quality measure in hospitals, a quality measure in long-term care facilities, and a quality measure in home care settings. The cost associated with providing care to patients with pressure injuries approaches almost $6.5 billion per year. That cost specifically ranges from $20,000 to $151,000 per pressure ulcers per individual patient per year. Pressure injury is a major risk factor. It is a major risk management issue, and it accounts for as much as 17,000 litigations, 17,000 lawsuits filed annually. How do patients with pressure injuries present? Many patients with pressure injury may complain of underlying pain. There may be associated infection, particularly at the site of the pressure injury. There's associated disfigurement, loss of limb. There's also an increased risk of mortality and decreased quality of life associated with pressure injury. In terms of some of the associated consequences of pressure injury is associated with longer hospital stays. It's also associated with an increased risk of 30-day readmission, prolonged rehabilitation, and an increased likelihood of being admitted to a skilled nursing facility or a long-term care facility. So how do we treat pressure injuries? A holistic interdisciplinary patient-centered approach is recommended. Timely examination and diagnosis is recommended. Goals of care should be aligned with the patient's wishes, so acknowledgement of advanced directives should be taken into consideration, utilizing the 4 HEMS healthcare model. Nutrition is very important. There's some evidence that 8 weeks of supplementation with food enriched with arginine, zinc, and antioxidants improves pressure ulcer healing. Pain management is indicated where pain is present, and it's strongly recommended to treat underlying precipitating factors or underlying factors, including medical conditions. Specifically, remove causative agents or insults. Pressure redistribution is strongly recommended. Therefore, repositioning of the patient, repositioning of the older adult at least every 2 hours is recommended. And finally, wound bed preparation. So what is wound bed preparation? So the principle of wound bed preparation aims towards reestablishing an acute wound environment to stimulate the healing process. What does this mean? Taking measures to clean the wound, employing measures to select products to address exudates, to address moisture, and to address bacteria and bacterial overgrowth and infection. Debridement, whether enzymatic, mechanical, or autolytic, has proven to be beneficial in wounds that are necrotic or wounds that are maybe infected, leading to necrosis. Adjuvant therapies include electrical stimulation, therapeutic ultrasound, light therapy, negative pressure wound therapy, and hyperbaric oxygen. Treatment of pressure injury also includes utilization of wound products. The choice of effective evidence-based treatment is limited, and this is primarily due to the lack of research or the lack of controlled clinical trials and other reliable measures of efficacy to justify using a particular product. And this is also because most wound care products are classified by the Food and Drug Administration as a medical device and not necessarily as a pharmaceutical. Therefore, manufacturers are exempt from the requirement to demonstrate efficacy. So the choice of wound product is often influenced by 1. Expert opinion, 2. Personal preference, 3. Product availability, 4. Product type and rationale, 5. Insurance coverage, and 6. Other cost considerations. But the correction of underlying causative factor is more important than the choice of topical agent or the choice of dressing. So it's important to note that. This is a list of some of the common wound treatment modalities. This is a very busy slide. It lists the type of treatment modalities such as gauze, hydrocolloid, hydrogel, and foam. It also lists the content and the reason or the rationale for using that particular type of wound treatment modality and some of the best settings in which to use them. Palliative care for wounds. A wound is classified as palliative when the wound is unresponsive to therapy. Also, when the process of healing is inconsistent with the patient's goals of care. A wound is also classified as palliative when there's no realistic chance of healing and when the burdens of treatment exceeds or outweighs the benefits of treatment. So what is recommended in the setting of palliative wound care? 1. Provide counseling. 2. Provide emotional support. And 3. Apply the guidelines of the following mnemonic. 1. Stabilize the wound. 2. Take measures to prevent new wounds or new wound formation. 3. Eliminate odor. 4. Control pain. 5. Control and prevent infections. 6. Utilize absorbent wound dressing. And 7. Lessen or reduce the frequency of dressing changes. So let's transition to urinary incontinence. To brainstorm for a minute, what is urinary incontinence? And what are some of the consequences of urinary incontinence? Why is this relevant? It's relevant because we practice evidence-based medicine. It's relevant because our assessments and intervention should translate into an improvement in quality of life and an improvement in life expectancy. Another way of saying that, it should translate into a decrease in morbidity and mortality. And this should be guided by the principles of the 4 M's framework. This is also relevant because incontinence is manageable. Our interventions and assessments can treat urinary incontinence, so it's relevant. It's preventable also. What's the definition of urinary incontinence? Urinary incontinence is involuntary leakage of any amount of urine. Now, this is important because urinary incontinence in the older adult may not represent a specific pathophysiologic entity. Compare this to urinary incontinence in a younger adult. In a younger adult, urinary incontinence is linked or caused by a specific pathophysiologic problem, or it may be caused by some sort of damage to the lower urinary tract or the pelvic floor. That's not the case in an older adult. In an older adult, urinary incontinence is associated with multiple underlying problems, either occurring individually or in combination. So, for example, urinary incontinence in the older adult is linked towards multiple comorbidities, or it may be linked towards medications, or it may be associated with functional and or cognitive impairment. So urinary incontinence is a classic geriatric syndrome. It is a classical geriatric syndrome in which multiple risk factors interact with one another, and they interact also with other modulating factors to produce a clinical phenotype. Okay? Overactive bladder is a term used to describe uninhibited bladder contractions. Okay? Overactive bladder leads to urgency. Okay? And this urgency may be with or without urinary incontinence. There are 4 types or 4 categories of urinary incontinence. The first is urge urinary incontinence. In urge urinary incontinence, the older adult has a compelling urge and often a sudden urge to void. There's also stress urinary incontinence. In stress urinary incontinence, there's leakage associated with increased intra-abdominal force, increased intra-abdominal force that's generated by maybe coughing or sneezing or laughing and or physical activity. Okay? Then there's the mixed picture. Urge incontinence in combination with stress urinary incontinence. And finally, there's urinary incontinence related to incomplete or impaired emptying of the bladder, which is sometimes termed overflow urinary incontinence, and it's related to an increased post-void residual. It's characterized by an increased post-void residual, often with symptoms of dribbling small amounts of urine. In overflow incontinence, typically the post-void residual volume exceeds 200 milliliters of urine. What are some of the risk factors for urinary incontinence? And there are a variety of them. It includes cognitive, environmental, functional, medical, medications, dysfunction to the lower uterine tract, and others. So underlying medical conditions may increase the risk of developing urinary incontinence. For example, obesity, functional impairment, injury to the lower uterine tract, mobility problems, manual dexterity issues, cognitive impairment, for example, in the setting of dementia, where the individual may not remember or may not sense the urge to go void. Medications can increase the risk of urinary incontinence. Environmental barriers, availability and access to the restroom, and motivation. These are all risk factors contributing to urinary incontinence. In older adults, continence depends not only on lower uterine tract function, but also on the ability to toilet, which requires sufficient physical function, cognitive motivation, and availability of toilets. Let's consider the prevalence and consequences of urinary incontinence. Prevalence. The prevalence increases with age. In addition, the prevalence increases with the need for assistance with activities of daily living. As much as 30% of older adults above the age of 65 years, report urinary incontinence. And as much as 70% of individuals in long-term care facilities report urinary incontinence. Urinary incontinence tends to affect women greater than men at a 2-to-1 ratio until the age of 80 years old. The cost associated with urinary tract infection, the cost and burden. There's an increase in caregiving time. There's an increase in caregiver burden. There's also an increased economic burden to the count of $26 billion annually. Urinary incontinence significantly impairs quality of life and general health. It's associated with an increased risk of morbidity. It's associated with an increased risk of a decreased sense of emotional well-being. In the setting where social activities may be maintained, it's associated with an increased risk of just the burden of coping, and an increased risk of embarrassment, and an increased risk of poor self-perception. Urinary incontinence also impacts independent functioning. Urinary incontinence may lead to social withdrawal and social isolation and even depression. So what are some of the causes? Or what does urinary incontinence contribute to? It impacts the general health. So it may increase the risk of developing dermatitis or cellulitis, increased risk of pressure-induced skin injury, increase the risk of urinary tract infection, increased risk of falls and complications of falls, increased risk of sleep deprivation, increased risk of social withdrawal, sexual dysfunction, and again, it's associated with an increased risk of depression. How do we manage urinary incontinence? The general goals or principles include decreasing pain and suffering, improving social role, increasing emotional and interpersonal relationship, improving sexual function and relationships, improving self-perception, and finally, minimizing the financial burden. Specific treatments may include lifestyle intervention, behavioral therapy, medications, and/or surgical intervention. How do we treat urinary incontinence? Treat the underlying cause. Treat the precipitating agent. Correct contributing factors. Eliminate contributing factors as much as possible. Behavioral therapy may include prompted voiding in patients with cognitive impairment. Prompted voiding. Bladder training. Medications such as oxybutynin and tolterodine are beneficial. Minimally invasive procedures and the surgery are also beneficial. In terms of primary prevention, lifestyle modification is indicated. Weight loss to reduce the risk of stress urinary incontinence, avoiding excessive or extremes of fluid intake, avoiding caffeinated beverages, avoiding alcohol, and avoiding smoking. Supportive measures may include pads and protective garments, and there is a role for condom catheters, which is superior to indwelling catheters in that indwelling catheters may increase the risk of infection and other complications. Let's transition now to gait abnormalities. To brainstorm, what is gait? What is normal gait? What is abnormal gait? And again, why is this relevant? This is relevant because our assessment and our intervention should translate into an improvement in quality of life and or life expectancy. This is relevant because gait disorders are common in older adults. This is relevant because gait disorders are a predictor of functional decline. This is relevant because functional decline clearly impacts ADLs and IADLs. Functional decline also correlates with disability and falls. So gait disorders correlate with disability and falls. Why is this relevant? It is relevant because the cause is multifactorial and it's also treatable. Interventions, again, decreases morbidity and mortality. In terms of epidemiology, in non-institutionalized older adults, as much as 20 to 50% of older adults admit difficulty walking, as much as 50% admit a need for some degree of assistance, whether it's a person or whether it's a specialized equipment such as a cane or a walker. Gait changes correlate with age, and gait abnormalities, the prevalence is greater with a greater number of underlying medical problems in the older adult. If the older adult has slowed speed, if the older adult has 3 or more underlying medical problems or chronic diseases, or if the older adult has had a stroke, a hip fracture, or any malignancy, it's a clear predictor of gait abnormality and loss of ability to walk. So what is gait? What is gait? Gait is simply the manner in which an individual walks. So it's a particular way of walking on foot. Abnormal gait is characterized by a change in speed such that the walking speed is slowed. There's a decreased stride length. There's diminished step height. Abnormal gait is also characterized by a deviation from the path of walking, lack of smoothness or asymmetry, and sometimes abnormal gait is described as it simply appears abnormal. Here's a question to consider. Abnormal gait is a consequence of aging. Abnormal gait is a consequence of aging. True or false? And the answer is false. This is a misconception, and it's good to be mindful of ageism, meaning not generalizing or stereotyping simply based on age. So abnormal gait is not necessarily a consequence of aging, but rather it's a manifestation of age-related diseases. Senile gait disorder is a term used to describe certain changes that are noticed in the older adult as the older adult ages. Senile gait disorder is sometimes termed idiopathic gait or essential gait, and it is an age-related gait disorder without any accompanying clinical abnormalities sufficient to make a specific diagnosis. And this is important because evidence supports that individuals with idiopathic gait disorder or senile gait disorder may develop, or they're at a higher risk of developing non-Alzheimer's or vascular dementia. In other words, idiopathic gait or senile gait disorder may be evidence of subclinical cardiovascular disease. So individuals with senile gait disorder who are followed have an increased risk of mortality from cerebrovascular disease and or cardiovascular disease. What are some of the characteristics of senile gait disorder? It's characterized by a broad-based gait with small steps, decreased arm swing, smooth stooped posture, decreased flexion of the hips and the knees, uncertainty and stiffness with turning, difficulty initiating steps, and a predisposition to falls. What are some of the most common causes of abnormal gait? Some of the most common causes of abnormal gait includes degenerative joint diseases, osteoarthritis, degenerative joint diseases, acquired musculoskeletal deformities, claudication, post-orthopedic surgery with impairment, cardiovascular diseases with residual effects, or cerebrovascular disease with residual effects, postural hypotension, and visual impairment. Those are some of the most common causes of abnormal gait. Some examples of abnormal gaits include antalgic gait, circumduction, echinovarus, festination, foot drop, foot slap, genu recurvatum, propulsion, retropulsion, scissoring, steppage, Trendelenburg, and turning block. So let's transition to falls in the elderly. Why is this relevant? It's relevant, again, because we practice evidence-based medicine, and our assessment and intervention should translate into an improvement in quality of life and life expectancy. This is relevant because falls are common and they correlate with age. In individuals above the age of 65 years, as much as 60% report falling in the past month, and as much as 33% report falling in the past year. In individuals above the age of 80 years old, more than 50% of them report falling each year. If the individual has a history, if the older adult has a history of falling in the previous year, the annual incident approaches 60%. Why is this relevant? It's relevant because every 17 seconds an older adult is treated in the emergency room for complications associated or related to a fall. Why is this relevant? It's relevant because every 30 minutes an older adult will die from injuries sustained in a fall. This is also relevant because there's a tremendous economic or healthcare burden that's associated with falls. The direct cost is attributed to ER visits, emergency room visits, hospitalizations, outpatient visits, physical therapy, medications, and the cost associated with assistive devices. Indirect costs are related to disability, work loss, compensation, mental or emotional anguish, property damage, litigation, and law enforcement. So what is a fall? What is a fall? These are examples or images of a fall. But what is a fall? What's the definition of a fall? A fall is a sudden, uncontrolled, unintentional loss of balance that leads to failure of postural stability. It's also a drop or descent of the body under force of gravity to the ground or floor or other lower level. What are some of the consequences of a fall? Falls impact quality of life and life expectancy. Therefore, falls can threaten independence and lead to disability. Complications of falls are the leading cause of death from injury in individuals above the age of 65 years old. So falls are not the leading cause of death in individuals above the age of 65 years old. The leading cause of death remains heart disease, strokes, and malignancy. But complications from falls are the leading cause of death from injury in individuals above the age of 65 years old. Most falls result in minor soft tissue injury. Some additional consequences of falls: approximately 1 in 3 or a third of those who fall need medical attention or need to restrict physical activity. As much as 15% of falls, 15% result in fractures, and 5% of falls result in serious soft tissue injury or head trauma. Among those who do not experience physical injury, falls are associated with a decline in functional status, a greater likelihood of nursing home placement, increased use of medical services, and again, development of fear of falling, which can lead to social isolation and depression. So let's brainstorm. Why do older adults fall? If an older adult has a history of a fall, then the risk of a recurrent fall is greater. Medications may also lead to falls. Osteoarthritis, degenerative arthritis, gait and balance abnormalities, mobility abnormalities can increase the risk of falling. Deficits related to Parkinson's and strokes and/or other neurologic problems can lead to falls. Postural hypotension can lead to falls. And fall risk is also increased with age-related changes, such as changes in the individual system or changes in the proprioceptive system or changes in the vestibular system. Those changes may lead to an increase in the risk of falls. And finally, environmental hazards may lead to falls. How do we prevent and how do we treat falls in older adults? A multidisciplinary team-based approach is recommended. A team-based approach that incorporates not only the PCP, not only the primary care physician, but also includes or incorporates other specialists, including the physical therapist, the social worker, the family, the psychiatrist, the ophthalmologist, and the pharmacist. It is also recommended to use a multi-component evidence-based approach that takes into account addressing identified risk, eliminating identified hazards, treating underlying medical problems, and removing environmental hazards. Therapeutic lifestyle modification is also important. So dieting is important, exercising is relevant, and weight management is relevant. Offer an exercise program to incorporate balance, gait, and strength training. In terms of specific intervention measures, medical management may include treating underlying causes. In the setting of visual impairment, address vision issues. For example, in the setting of cataracts, cataract surgery may be indicated. Manage postural hypotension, manage heart rate and rhythm abnormalities, minimize the use of medications. Interval review or medication reconciliation is indicated. Taper or eliminate non-essential medications, including psychoactive medications. Supplement vitamin D. There's evidence to suggest that vitamin D supplementation in the scale of 700 international units to 1,000 international units is associated with a 9.5% absolute risk reduction in falls. Consider injections and heating modalities. Manage footwear and foot problems. Modify the home environment and eliminate environmental hazards. In terms of exercise, initiate an individually tailored exercise program. Incorporate more than one exercise regimen. Exercise as defined as repetitive, focused, task-specific activity. Improve strength. That's geared towards improving strength, improving flexibility, improving endurance, improving balance, and improving gait. There may be a role for supervised exercise or physical therapy, which is structured, repetitive, and focused. There may also be a role for electrical stimulation and or heat therapy. Assistive devices, depending on the situation, may be indicated, and surgery, depending on the underlying situation, may be indicated. Thank you.